As Canadians, and especially in this month of Truth and Reconciliation and Indigenous Awareness Month, we respect the self-determination of First Nations, Métis, and Inuit, and their rights and responsibilities in cultures, languages, and the pursuit of wellness. Personally, I'm grateful to work and play on the unceded traditional ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and wherever you are in this um, on Turtle Island, you too are reflecting and thinking about ways to improve your understanding of and care of our Indigenous peoples, elders past, present, and emerging. Province-wide rounds is a collaboration between the University of British Columbia Division of Nephrology and BC Renal. We have a number of industry partners who unrestrictedly support a number of educational activities, as well as each of you at the regional and health authorities. So thank you very much for all that you do. So today we have the privilege of hearing from Dr. Taewon Yi. He's a nephrologist and postdoctoral fellow at the University of Toronto in the Cardiovascular, Renal, Endocrine, and Metabolic Diseases Fellowship, otherwise known as CARE, I believe. He completed his internal medicine and nephrology training at UBC and earned a PhD at the University of New South Wales in Sydney under the direction of Dr. Meg Jardine. His PhD focused on improving the uptake of evidence-based therapies in chronic kidney disease and diabetes, and his interests include clinical trials and implementation science, with an emphasis on generating and translating evidence into routine clinical care. He's currently supported by a Canadian Institute of Health Research postdoctoral fellowship, Kidney Foundation of Canada Crescent Fellowship, and a Breakthrough Type 1 Diabetes Canada Clinician Investigator Fellowship, all of which have been awarded this year. So congratulations to him for that support. And I'll turn it over to you, Taewon, to give us your talk. So thank you.
Perfect. Thank you so much for the kind introduction. You can see the screen here. All good? Okay, perfect. Thanks. The talk today will be advances in cardio-kidney metabolic syndrome from pathophysiology to practice. And before we get started, I just wish to acknowledge this land which I am on today, currently on the traditional territory of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, the Chippewa, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis people, and we are grateful to have the opportunity to live, work, and gather on these territories. These are my disclosures. The three objectives that I'd like to cover during our talk today is to review the cardio kidney metabolic syndrome and the key pathophysiologic mechanisms involved, summarize the recent and emerging clinical trial evidence supporting CKM therapies, and apply evolving CKM management principles to multidisciplinary patient care. So cardiovascular kidney metabolic syndrome is defined by the AHA as a health disorder due to connections among heart disease, kidney disease, diabetes, and obesity, leading to poor health outcomes. These conditions are closely intertwined in their pathophysiology, and with the increasing rates of obesity and diabetes, these conditions are becoming the predominant phenotype for cardiovascular risk. It is a rapidly growing field with multiple new therapeutics available and emerging, which we will discuss today. So obesity-induced chronic inflammation is a key component in the pathogenesis of insulin resistance and metabolic syndrome. So normally, adipocytes release adipokines, which are hormones that influence metabolism, immune function, and inflammation. But in patients with obesity, it appears that the adipokine shifts to favor pro-inflammatory adipokines such as TNA alpha, interleukin 6, and leptin, while the secretion of anti-inflammatories like adiponectin is diminished. One theory that holds is the expansion of adipocyte tissue, which leads to hypertrophy and hyperplasia. And that large adipocyte outstrips the local oxygen supply, leading to cell hypoxia and activation of cellular stress pathways. And these processes in the crosstalk with skeletal muscle and liver promotes insulin resistance, leading to systemic insulin resistance and chronic inflammation. This is a study done using the NHANES data in the United States, where they used a clustering algorithm to identify cardiometabolic and renal phenotypes over a period of 30 years between 1998 and 2018. This figure shows age standardized prevalence of various cardiorenal metabolic phenotypes during this time period and represents what the primary phenotype or etiology is that makes up their cardiovascular risk. What's interesting is that you can see a steady decrease in high cholesterol and blood pressure, as outlined here in purple and blue, as a primary cause of cardiovascular risk over time, while you actually see a consistent increase in severe obesity and CKD in orange and the light blue in the same time frame. There is a steady burden of severe hyperglycemia, which is shown in the dark red in the middle there. So this is a conceptual diagram for the pathophysiology underlying CKM syndrome. It most commonly originates from excess or dysfunctional adipose tissue with multiple pathological processes leading to inflammation, oxidative stress, insulin resistance, and vascular dysfunction. These processes lead to development of metabolic risk factors like hypertension, dyslipidemia, metabolic syndrome, and diabetes, and also progression of kidney disease and the development of cardiovascular disease. And these risk factors and CKD further predispose you to having cardiovascular risks through multiple direct and indirect pathways. So what this figure adds to the previous, I think, is the importance of considering upstream determinants of CKM syndrome, like genetics, dietary and behavior exposures, environmental exposures, and particular social determinants of health, which is identified by AHA as part of their guidelines this year, as an important consideration in all aspects of assessment and management. And I think we as clinicians, we kind of tend to focus on the clinical aspects to manage this. And we often forget how important these upstream components are in health management. This chart on the left should be quite familiar to most people, and it's the KDIGO heat map with the CVD mortality risk across the CKD categories. On the right here, this figure is from a study that looked at baseline BMI versus mortality in 57 prospective studies, which included close to 900,000 participants, mostly in Western Europe and North America. And the analysis was adjusted for age, sex, and smoking status. And what this figure shows here is that around a BMI of 20, the all-cause mortality is lowest at around a BMI of 22.5 to 25. And as you start deviating away from this, the mortality goes up. And it's kind of estimated that about each 5 kilograms per meter square higher BMI is associated with around 30% higher mortality. So just to highlight that individual components in the cardio-kidney metabolic disease impart significant risks. In 2023, HA proposed a CKM staging figure or construct that reflects the pathophysiology spectrum of disease and opportunities for prevention and health care optimization, where stage 0 is no risk factors, stage 1 is excess or dysfunctional adiposity, stage 2 includes metabolic risk factors like hypertension, metabolic syndrome, type 2 diabetes, or moderate to high-risk CKD. Stage 3 involves subclinical cardiovascular disease in the CKM syndrome with risk equivalents such as very high-risk CKD or high predicted 10-year cardiovascular risk using the PREVENT CVD equation. And lastly, stage 4 is evidence of clinical cardiovascular disease in the spectrum of the CKM syndrome. So its purpose was to help identify individuals at high risk and try to have a unifying definition to facilitate discussion and research. And I do think there is value to trying to bring in complex and spectrums of diseases together into one kind of a visual format. But obviously with that, there are some limitations as it tends to oversimplify a complex nonlinear biology. And I guess from a nephrologist standpoint, essentially it introduces CKD as stage 2, no specific mentions of how to manage, investigate non-metabolic etiologies of CKD. And kidney failure is absent in the outcome. And not surprisingly, being developed by the AHA, it is cardiocentric. But nevertheless, I think this this type of figure helps us to think about and consider additional risk factors like obesity that we may not have thought of previously. It's not perfect, but does attempt to combine complex diseases into one figure. So CKM stages do correlate to cardiovascular outcomes. On the left here is an analysis from the ERIC study, which included 5,600 patients with echocardiograms who were then categorized into CKM staging. And among participants without prevalent heart failure, the risk of incident heart failure during follow-up increased as you add higher CKM syndrome stages. So there were no events in stage 0 or 1, so stage 2 was the reference group. And compared to that, in stage 3, there was 15.1 events per 1,000 patient years, which is has a ratio of 3.6, and in stage 4, it's 37.4 events per 1,000 patient years, translating to a hazard ratio of 8.3. On the right is the data from the NHANES, which looks at around 18,000 adults categorized into the stages. And as you can see, as the stages get higher, there's increased mortality and reduced life expectancy. So higher CKM stages equals worse CVD outcomes. So now we'll talk about new therapies that are coming along for the treatment of CKM. And today I'll just focus really on the new emerging kidney therapies. So this is the 2024 CKD KDIGO guidelines, and I know the 2026 version is up for public review at the moment, but this being the current guidelines, we'll quickly review the indications. And as you know, SGLT2 inhibitors are first-line therapies, and the current indications are listed there to the right. Next is non-steroidal MRAs, finerenone, which is indicated for people with type 2 diabetes, GFR of 25 or higher, and with the presence of albuminuria. GLP-1 receptor agonists. This guideline was pre-FLOW trial, but it is indicated for patients with type 2 diabetes and CKD who have not achieved individualized glycemic targets. So I know there's been a lot of emphasis and attention to having pillars of therapy, kind of like the cardiology now. And these are the current pillars of therapy. As you know, there are very well-established evidence for RAS inhibition, SGLT2 inhibitors, finerenone, and GLP-1 in type 2 diabetes and kidney disease. But as you can see, there's very limited evidence in type 1 diabetes, and though a little bit more exists for kidney diseases not associated with diabetes. But we'll talk about these two emerging pillars in more detail. So people with type 1 diabetes have significantly higher risk of cardiovascular disease and CKD compared to the general population. And they may even face a greater risk for CKD than those with type 2 diabetes. And patients with 40-year duration of type 1 diabetes, approximately 30% have evidence of chronic kidney disease, while onset of type 1 diabetes before the age of 10 is associated with a 30-fold increase in coronary artery disease in early adulthood. So it's critical to develop new treatments and modalities for such a high-risk group of patients. Other than this, the captive Pearl trial and done in the early 90s, there really hasn't been anything additional until earlier this year, which was finerenone being investigated for those with type 1 diabetes in the FIND-1 trial. So the FIND-1 trial evaluated effects of finerenone on albuminuria reduction in people with type 1 diabetes with a GFR greater, between 25 and 90, urine ACR between 20 to 560 on a stable dose of RAS inhibition. Exclusion criteria included type 2 diabetes or CKD with presumed from other causes other than type 1 diabetes. The primary endpoint was a change in urine ACR from baseline over 6 months, and they also assessed treatment-related adverse events and hyperkalemia. Table 1 here shows that around 120 were randomized to finerenone, 122 were randomized to placebo. The median urine ACR was around 500 to 575 and a mean GFR of 59. There was a similar use of RAS blockade in these patients. And the figure on the right here demonstrates the albuminuria. And there, over a period of 6 months, there was a reduction in 34% in those with finerenone and 12% in those with placebo. So finerenone was associated with a 25% decrease in albuminuria. The subgroup analyses were exploratory in nature, but shows relatively similar effects of finerenone on urine ACR across the subgroups. For important safety outcomes, there are only 2 events for serious hyperkalemia requiring hospitalization in the finerenone group, and only 2 events of K greater than 6 in the finerenone group compared to 1 in the placebo group. Now, as a quick side note, I thought I'd just chat about surrogate endpoints, particularly for maybe the fellows who are on the call, and talk about why they're used and why we might use this instead of traditional hard outcomes like kidney failure requiring dialysis or a sustained decrease in GFR. So trials evaluating treatments to slow CKD progression often require a very large sample size and a very long follow-up period, particularly if we're investigating patients with earlier stage of CKD because they're less likely to experience the outcome. And surrogate endpoints that occur earlier during the disease progression can be considered, like urine ACR reduction and eGFR slope. And this is particularly helpful in rare diseases where sample size might be a limiting factor. Like in the FIND-1 trial that I just presented, type 1 diabetes is a relatively rare condition compared to type 2 diabetes. And to try to follow them until they reach hard outcomes like kidney failure would essentially make the trial impossible to conduct given its duration and the financial implications of that. So this is a meta-analysis of 41 randomized controlled trials that conducted a Bayesian mixed effects meta-regression analysis on around 30,000 participants in a multiple different types of trials. So you can see RAS inhibitors, low protein diet, immunosuppression, empagliflozin, etc. The figure here on the right shows the meta-regression plotting, where the treatment effects on the urine ACR is on the x-axis, and the clinical endpoint is on the y-axis. And this model specifically highlights that a 30% reduction in albuminuria is associated with an average of 27% lower hazard for the clinical endpoint, which in this study was end-stage kidney disease or doubling of serum creatinine. And it becomes a bit more robust when it's assessed in patients with higher baseline albuminuria. So this is why some studies are now using albuminuria reduction as a surrogate marker for clinical outcomes. And this was what was demonstrated in the FIND-1 trial. So ideally, when you use a surrogate marker like urine ACR reduction or whatever surrogate marker you choose to use, like eGFR slope, you should demonstrate that the reduction in ACR accounts for the outcome you're interested in. And in our case, this would be the composite kidney endpoint of kidney failure or sustained 40% decline in GFR or kidney death. And you can get this through what's called a mediation analysis. And the authors show that the proportion of finerenone's treatment effects on this composite outcome was attributable to the change in the urine ACR was 87%. So with the data from the FIND-1 trial, I think it's quite clear that for type 1 diabetes, finerenone has become another key pillar in the management of diabetic kidney disease associated with type 1 diabetes. And now further exploring additional pillars of therapy in type 1 diabetes, we'll discuss ongoing studies in SGLT2 inhibitors and GLP-1 receptor agonists that are ongoing and not yet completed. So for SGLT2 inhibitors, currently, sugar and salt trial is underway and active recruiting patients with type 1 diabetes. It's being done in BC as well. So there are two main purposes to the trial. The first being to determine the effectiveness of sotagliflozin, which is a SGLT1 and SGLT2 inhibitor in slowing eGFR decline, and also to evaluate the feasibility of implementing an enhanced diabetic ketoacidosis mitigation protocol for the safe use of sotagliflozin. As you know, there's approximately like a 2 to 3-fold increase in risk of diabetic ketoacidosis with SGLT2 therapy in type 1 diabetes. The sugar and salt trial is going to randomize 150 patients with type 1 diabetes with a GFR between 20 to 60 and urine ACR of more than 200 to receive sotagliflozin or placebo for 3 years. And the primary outcome will be eGFR at the end of the 8-week drug washout period following the treatment. And the reason for this washout period and why we're measuring the GFR at that point is there is a hemodynamic effect of SGLT2 inhibitors, and I think most people are aware that you see a dip in GFR once you initiate SGLT2 inhibitors. And the idea of doing this in washout is to show what the true underlying GFR is for those who were on sotagliflozin compared to the placebo group. So hopefully we'll see SGLT1 and 2 inhibitor sotagliflozin as an additional pillar for the treatment in type 1 diabetes. And now we will talk about an ongoing trial for GLP-1 receptor agonist. So Remodel T1D is an ongoing study currently recruiting patients with type 1 diabetes, urine ACR of more than 3, and a GFR greater than 30 to be randomized to semaglutide or placebo for 6 months. The primary outcome is a measurement of oxygenation measured by MRI from baseline to 26 weeks. Secondary outcomes include changes from baseline to 26 weeks in albuminuria, insulin dose, eGFR, and glycemia targets. This is just a study population for Remodel T1D. And just as a sidestep, You might be wondering, like, where did all this kind of oxygenation, MRI outcomes come from? And it's actually based off of the Remodel trial, which was a mechanistic study and a 52-week RCT looking at semaglutide in patients with type 2 diabetes and CKD. The primary outcome was MRI oxygenation, and secondary outcomes include urine ACR reduction, 24-hour creatinine clearance, and exploratory outcomes, which was very interesting, with kidney biopsies, single nucleus RNA sequencing, and spatial transcriptomics. So although there was no statistical difference in the kidney oxygenation or kidney perfusion, the primary outcome, those who received semaglutide had significantly lower perirenal and sinus fat volumes, as you can see here and here, by 25% and 13% respectively. There was also reduced renal arterial resistive index in the semaglutide group, which reflects lower renal vascular resistance. And it's interesting, as we know from FLOW and other semaglutide trials, that semaglutide helps to preserve GFR and lower albuminuria. And these changes in perirenal and sinus fat could possibly be one of the many explanations on the mechanism of action, by possibly removing pro-inflammatory adipose tissue and maybe even physical congestion around the renal hilum. This is a bit of a busy slide, but we'll kind of guide you through here. So on the top left, the kidney biopsies underwent a single nucleus RNA sequencing, which shows the major cell types in the nephron. And of these, you can see that the glomerular endothelial cells were most semaglutide responsive cell type, with the most downregulated genes associated with metabolic dysfunction and fibroinflammation. On the right here shows the periglomerular region, which initially shows some tubular interstitial inflammatory response with mononuclear and lymphocytic infiltration here. And it was lower after 52 weeks of semaglutide. Spatial transcriptomics of the glomerular endothelial cells demonstrated that natural killer T cells and macrophages and monocytes were depleted within 25 microns of the glomerular endothelial cells. So you can see here there were the natural killer T cells and macrophages, and after being treated, they are gone from the glomerular endothelial cells. So I think it's quite fascinating to see that we're able to see at a cellular level, biopsy level, how semaglutide may exert its effects beyond quote unquote weight loss. And semaglutide clearly has multiple pathways on how it results in kidney function outcomes, like reducing albuminuria and preserving glomerular filtration rate. And it can be done through multiple pathways as demonstrated in the Remodel trial. So now that we highlighted the role of finerenone in type 1 diabetes through FIND-1 trial and ongoing studies with sugar and salt and Remodel T1D in type 1 diabetes, let's look at finerenone in the context of kidney diseases beyond type 1 and type 2 diabetes. So the FIND-CKD trial was published quite recently. It was randomizing close to 1,600 participants with either a GFR of 20 to 60 with a urine ACR between 200 to 500 milligrams per gram, or a GFR of 25 to 90 with a urine ACR of 200 to 3,500 milligrams per gram, to either finerenone or placebo for 32 months. Patients with type 2 diabetes or type 1 diabetes were excluded, and those with a hemoglobin A1C of 6.5 or higher were excluded as well. The primary endpoint was a change in eGFR as measured by the total slope of eGFR, and the secondary outcomes included pre-specified hierarchical testing like composite kidney and cardiovascular events. And the FIND-CKD trial was calculated to have over 90% power to assume a mean annual rate of eGFR decline of 0.7 less with finerenone versus placebo. And here are the baseline characteristics. And as you can see, 793 were in finerenone, 791 in placebo. What I do want to point out is that more than 50% had chronic glomerulonephritis, and low number of patients were on some concomitant SGLT2 inhibitor. This is a slope in the placebo group where the total eGFR slope is -4 mils per minute, while the GFR slope of the finerenone group was -3.3 with a difference of 0.7, which was statistically significant. In this slide, or in this additional diagram, this is a GFR slope after the washout period, where you can see an increase in GFR of 1.2 in the finerenone group, which kind of relates to the hemodynamic effects of finerenone, and a further decline in the placebo group by 0.5. The effects of the slope were consistent by pre-specified subgroups of CKD etiology, eGFR, urine ACR, and baseline SGLT2 use, with no differences observed between groups. The secondary outcome of composite kidney and cardiovascular outcome, which included sustained more than 57% decrease in GFR from baseline over 4 weeks, kidney failure, hospitalization for heart failure, or cardiovascular death. And it was statistically significant with a hazard ratio of 0.77. Overall, looking at the composite of kidney failure and sustained 40% decrease in GFR by glomerular disease subtype, there was a 26% reduction in this outcome with finerenone versus placebo, and no differences by disease subtype, whether it's IgA nephropathy, FSGS, other glomerular diseases, membranous, or MPGN. This is actually a separate paper published by the FIND-CKD group, and it's been published in JAMA after the ERA. So similarly, looking at albuminuria as a surrogate, you can see that the eGFR slope can also be used as a surrogate outcome. On the left here, you can see a similar Bayesian mixed effects meta-regression to demonstrate that preservation of 0.5 to 1 mil per minute per year with a sufficient sample size can demonstrate a 27% lower hazard for the clinical endpoint, which is kidney failure, doubling of creatinine, or GFR less than 15. On the right, this again was demonstrated using observational data of more than 3.7 million participants, which demonstrated that slowing GFR decline by 0.75 mils per minute per year over 2 years was associated with 30% lower hazard for end-stage kidney disease. And this is why these trials are using kind of values, eGFR difference and values kind of 0.7 to 0.75. So lastly, I want to quickly talk about the use of semaglutide in kidney diseases without diabetes. So the SMART trial randomized 101 individuals to semaglutide at 2.4 to a target dose of 2.4 milligrams once weekly, and a matching placebo for 24 weeks, which for 6 months, or close to 6 months. This included people who were adults with a GFR of 25 or higher, urine ACR of 30 to 35, 100 milligrams per gram, and a BMI of 27 or higher, and people with diabetes were excluded. And those in the semaglutide group experienced a geometric mean reduction of urine ACR by 52.1% compared to placebo. And although this wasn't the biggest trial, given that it was only 101 participants, this may not be enough. This trial alone might not be enough to for indication changing for non-diabetic kidney disease and GLP-1, but there are new studies that are ongoing, which we will quickly highlight. So to summarize the current evidence, I think we're making significant progress and building more and more of these pillars for the treatment of chronic kidney disease of all etiologies. So this is a diagram of how the development of kidney diseases can be contributed by multiple pathways. And so you can start here with angiotensin 2, which is inhibited by RAS inhibitors. This angiotensin 2 can activate aldosterone synthase, which in turn activates the aldosterone pathway. And angiotensin 2 also works with endothelin 1 to activate endothelin receptor A, which contributes to the pathophysiology of chronic kidney disease. As well, it also contributes to the generation of advanced N-glycemic products and cytokines, which in turn has downstream effects on JAK signaling and signal transducers and activators of transcription. As you are all aware, RAS inhibitors and mineralocorticoid receptor agonists are current therapies that use, and there are some emerging therapies that specifically target these pathways that I'd like to highlight. So first is the endothelin receptor antagonist. Currently, zibotentan is a highly selective endothelin receptor A antagonist used in combination with dapagliflozin to assess GFR slope in the Zenith high proteinuria trial. There's also vicadrostat and baxdrostat currently under investigation for aldosterone synthase inhibitors. Easy Kidney is currently recruiting, and I believe is also recruiting in BC as well, and is assessing empagliflozin and vicadrostat on kidney disease progression and cardiovascular outcomes as well. Baxdrostat is more in the realm of management of resistant hypertension in the context of both kidney disease and non-kidney disease. There is a monoclonal antibody, ziltivekimab, which is a monoclonal antibody to the IL-6 in the inflammatory pathway, which has completed recruitment, and we are awaiting results. The ZEUS trial is assessing cardiovascular outcomes with kidney secondary outcomes in about 6,200 patients with stage 3 and 4 CKD and elevated high sensitivity CRP levels. JAK1 and JAK2 inhibitors are again another potential target, and there is some preclinical data with baricitinib, which hasn't really shown yet to translate into clinical benefits. And now we also have what's kind of being called multi-hormone receptor modulators, which are currently under investigation. So Treasure CKD, which is fully enrolled, is looking at tirzepatide, which is a dual agonist for GLP-1 receptor agonist and GIP receptor agonist, evaluating its effect on obesity and chronic kidney disease with or without type 2 diabetes. This is similar to kind of the remodel trials where it's looking at MRI for its outcomes. And lastly, Triumph Outcomes, which is looking at retatrutide, which is a triple agonist, GLP-1, GIP, and glucagon, which is assessing 10,000 patients with obesity, looking at kidney and cardiovascular outcomes. So a lot of new medications under horizon at this time. I think this is a very nice diagram to show how the GFR trajectories can change with the incremental addition of new therapies. The gray line here represents kind of aging associated decline, and the red here being diabetic nephropathy with albuminuria, which can range from a loss of 6 to 8 mils per minute per year. With addition of these therapies like blood pressure control, RAS inhibition, SGLT2 inhibitors, MRAs, and GLP-1 receptor agonists, and possibly more to come, I think we will see a time when you can kind of flatten this GFR slope to essentially match this aging associated decline. And even anecdotally in our clinics here, we've seen patients who have complete remission of their albuminuria, and for a couple of years there, there's been no changes to their GFR, and we've actually discharged patients back to their family physician. And with the advent of these medications, there's really a theme of remission, where historically the goal was to delay I guess, unfortunately, the inevitable loss of kidney function, as there are few effective therapies with a major focus on provision of dialysis and kidney transplantation. Now, with these new therapies, the focus has really shifted to, can we halt the decline of kidney function to normal healthy aging associated loss, or even achieve normalization of GFR and albuminuria? The diagram here on the bottom, it shows a rate of eGFR decline in the active arms of the diabetic kidney disease trials, and here the IgA nephropathy trials. And as you can see over time, with the layering of these therapies, you can really see that the GFR slope in the trials substantially attenuate over time to like a GFR close to 1, which is kind of what we think is normal healthy aging. And as an example here, in the early studies comparing RAS inhibition with placebo in patients with diabetic kidney disease. Those in the placebo arms, you're approaching 10 to 15 mils per minute loss per year, with a modest attenuation of maybe 8 to 10 with captopril. Where now, if you kind of look at the numbers here, looking at a subset of those of patients on RAS blockade and SGLT2 inhibitors in the FLOW trial, you can see that the chronic GFR slope declines are close to 1.3 to 1.5 mils per minute. So a few weeks ago, AHA released their guidelines for prevention and management of CKM syndrome. They provide detailed guidelines on how to manage this by the CKM stages. But personally, I do think it lacks a bit of the granularity of what I think the KDIGO guidelines show. So I won't go into too much detail about each treatment algorithms per stage, but they are up and available for your review. One important tool that I'd like to highlight that AHA has incorporated is the PREVENT calculator, which can calculate 10 and 30-year risk for CVD, ASCVD, and heart failure. And I think this tool and this risk calculator can be used together for our patients using the KFRA. So perhaps use both the kidney failure risk and cardiovascular risk prediction with the PREVENT tool. So the care for patients with CKM should follow essentially a multi-dimensional, multi-stakeholder and multidisciplinary approach for prevention and treatment, centering the importance of empowering the patient themselves. This idea of siloed care, cardiology in its own silo, nephrology and endocrinology to each their own, should really be transitioned more into an integrated care approach, and ideally would be supported from a public health policy as well as healthcare financing as well. So, and this concept of integrated care clinic has been tested 15 years ago at St. Paul's, where patients were randomized to see a combined clinic with cardiology, endocrinology, and nephrology, or still follow up with them, but the three specialties separately. While there were no differences in hard outcomes between combined versus multiple clinic groups, this really was a time when the only real evidence-based therapy was RAS inhibition. And you can really imagine what could potentially be accomplished today with all the new emergent therapies, given that we have so many new options. Even then, there were improvements in symptom control and reduced specialist visits, which in turn improved quality of life and the substantial costs to the healthcare system. And there was an estimated cost savings of $250 million per year. And imagine now with all these therapies using all four or five that with the emerging therapies, how drastically we can actually move the needle in remission and patient care and kind of effects on the healthcare costs. More recently, this trial here showed that patients who attended these clinics supported by a multifaceted intervention, including a study cardiologist, endocrinologist, and an implementation scientist. Patients had a 4-time higher odds of being prescribed all three therapies for type 2 diabetes and atherosclerotic cardiovascular disease. So the benefits that you'll see for our patients to get them on all four pillars for diabetic kidney disease would be substantial if we were able to get majority of them on these treatments. Currently, just examples of multidisciplinary CKM clinics in Ontario. I'm part of the care clinic here. Actually, we're just doing clinic right now. I had to step away just to give this talk, but it is comprised of nephrology, cardiology, and endocrinology, and supporting teams of dietitian, a chiropodist, ophthalmology, and pharmacist to have a patient-centered multidisciplinary care, quote unquote, one-stop shop for these patients. There is the Decide CV clinic, which is similar in nature, going in McGill University, which is very similar to the care clinic. But I believe in I believe in the CV clinic, it might be just the endo and nephrology with addition of cardiology here and there, but I might be mistaken on that. So in summary, early identification of individuals at risk for CKM and timely risk-based interventions are essential to improve long-term outcomes. The therapeutic landscape for CKD is evolving rapidly with expanding treatment options for CKD with or without diabetes. And we should really move towards move beyond disease-specific silos and aim towards integrated multidisciplinary CKM care as it's critical delivering evidence-based and patient-centered treatment. And that's the end of my talk. Thank you very much for your attention.
Thanks, Taewon. There are lots of people online. There's a question from Dr. Hendren. Many of the transplant patients fit the CKM phenotype. Do you think that transplant-specific trials are needed to assess safety and efficacy, especially for the CKD indications? And do you know if anything is planned in this area?
Yeah, I think the best person to answer that question actually might be Dr. Vic Sridhar, who I think is online. There are active studies going on, which are transplant specific. We are couple ones that we're running right now at UHN is the Hallmark study, which is more of a mechanistic study looking at SGLT2 inhibitors and GLP-1. But I believe there are bigger, multi-site clinical trials planned to assess patients who's received a kidney transplant and specifically these medications for use.
I just wonder if, we should have basket trials, right, where we have different, like, native kidneys and transplant kidneys all within one protocol, because like having to run all these trials separately with infrastructure is a little bit of a problem. Any other questions? You can raise your hand and we'll unmute you, or you can write it in the chat. Oh, I see there's another one in the chat. Oops, it is.
Caroline, new drug trials include environmental outcomes. experts have called for this in RCTs along with conventional clinical endpoints. Yeah, that's a very good question, and we know firsthand with you leading a lot of this important work that there are huge environmental impacts with CKD and dialysis. But from what I know currently, I don't believe that there are any specific environmental outcomes throughout the actual trial itself. There may be stuff looking at secondary analyses or, the downstream effects kind of from the study results, but I don't believe that it's actually part of primary or secondary outcomes in the current studies that are ongoing.
Great. Liz, do you have another question? Your hand is still up, so just want to make sure that we've answered you. Or do you want us to unmute you? Okay.
Even see that option.
Okay, you don't see the way to put down your hand. Okay, no problem.
Not on this platform, so I don't know how it got raised.
Okay, no problem. Other questions or comments? I mean, I think, as you said, Taewon, it's certainly a very exciting time, and how to get, I think sometimes certainly what I hear from both GPs as well as patients is that one doctor suggests a drug and then they go and see another doctor and they say, well, no, I don't think so, or they take them off it. And I think that, I do think we probably have to figure out a better way to talk to each other as subspecialists, perhaps, in order to get this. There's someone else that has their hand up, unless that's still Liz. But oh, Carolyn, go ahead, Carolyn.
Hi, yeah, I can now talk. Thank you for the earlier answer. So there's a lot of drugs coming down the pipeline here, and I was just wondering if you had any insights for which one or ones might be headed our way next. And also, apologies if I missed this, but I'm using a lot of finerenone now, as hopefully we all are. And is that one reimbursed provincially for people who do not have type 2 diabetes?
So maybe I can answer the second one, like,
perfect,
no,
yeah.
it's not. But if you can afford it, and what some of our pharmacists are doing is it's the same price for the 10 milligram and the 20 milligram tablets. So even if you order 10 and if you want them to be on 10 and you order a 20, then you actually get twice as much drug for the same price. So that's a way to cut costs. But it's not yet reimbursed. I believe that, we'll try and make a case for it but Health Canada, sorry, I think the CPS or someone else can figure out how best to get it for all people without diabetes.
Yeah, that's a similar case in Ontario as well. Hasn't been approved for type 1 diabetes, so people are paying out of pocket, even though meds for patients over the age of 65 are covered. So we're again, that's another financial kind of barrier for patients with type 1 diabetes. And I'm so sorry, I forgot the first question, first part of the question. Do you mind if you don't mind repeating it?
Oh, that's okay. Adira answered it.
Perfect.
Other questions?
Thank you.
Oh, thanks, Carolyn. Looks like you answered everything. Yeah, thank you so much. I mean, we've got 6 minutes, but I think that, what you've given us, I think, which is really important, is that a lot of these medicines are working in a multiplicity of ways in people, right? And I think it's good for us to understand all the mechanisms. So especially for the people prescribing them, being able to explain to patients how it works. It's not just weight loss. A lot of people don't want to take the GLP-1s because they think it's all a fad and they hear all these bad things about it. Have you come across that? Because a lot of our friends go, there's lots of side effects and I'm going to have to be on it forever and I might go crazy. Like there's various things.
Yeah. And I think we usually just highlight that the weight loss is not the reason we're prescribing it. It's really the kidney protection, heart protection, reducing albuminuria, and just kind of frame it as, if you lose weight and you're in the higher BMI, great. That's kind of like a quote unquote, expected side effect. But it really is for kidney protection and heart protection and the reasons why we're using it.
Great. And there is another question. For patients with type 2 diabetes receiving finerenone, at what point do do you recommend discontinuing the therapy if the serum creatinine continues to rise, but the eGFR, urine ACR, and potassium are stable? Can an isolated increase in creatinine alone be used as a reason to stop finerenone?
So patients with type 2 receiving finerenone, serum creatinine continues to rise, but GFR remains stable. I've very hard question. I've really never seen this in this very highly specific context of not only creatinine rising, to be honest with you. But I think it might, applying kind of perhaps the principles that we use for like RAS inhibitors and SGLT2, if it's like a huge unexpected drop, look at other potential causes for it. But to be honest, I haven't really seen just isolated creatinine rise, but stable potassium levels.
And stable GFR would be unusual, right? But I think the principle, like all of the studies, if I remember correctly, but you can correct me, they all continued finerenone until people started dialysis. So like we took a long time to learn not to stop ACE inhibition just because the kidney function continued to deteriorate because there was no benefit to it other than changing a number. And I think hopefully we don't have to take 20 years to learn that about these other agents. Is that the practice in Toronto, is to leave people on it?
Yeah, I think that like SGLT2 inhibitors, finerenone, continue, like start them when their GFR is appropriate and then just continue on if they progress to kidney failure.
Great. And
Okay.
yeah, so it's just giving, there's no such, I don't know a world in which your creatinine goes up and your GFR is stable, Natasha, so maybe they're just misunderstanding something.
Or just like nothing other changes like the potassium. So I'm not saying it didn't happen, but it's just we've never seen it before. So I'm sorry, I can't really comment on that specific scenario.
Anyway, Michelle.
I just have a question about some of my patients that do progress to either PD or IHD, and they have associated cardiac dysfunction that's chronic and ongoing. How about continuing with, say, the finerenone or the SGLT2 inhibitor with
very
end
good
stage?
question. Yeah, very good question. So there's an ongoing study by Dr. Heerspink, the renal life cycle, which is looking at SGLT2 inhibitors and all ranges of GFR, including people on dialysis and PD. So the results from that trial will be very helpful. But I guess clinically, if we talk about SGLT2 inhibitors, because they kind of work in the kidneys, if someone has no urine output, I'm not sure what the incremental benefit could be. If we talk about sotagliflozin, which has SGLT1 and 2 inhibition, and SGLT1 is kind of primarily in the gut, I think that could be a different discussion. But in patients on hemodialysis, no residual urine output or renal function, I don't know if there is no data to suggest there's benefits. And as for finerenone, again, lack of data in this. There was recently a spironolactone in hemodialysis trial, which was halted for lack of effect. So again, finerenone is slightly different from spironolactone, but if we were to extrapolate that data, we don't think finerenone would have significant benefits in patients on hemodialysis. But again, there's no data to guide that discussion.
Thank you.
And I think, Marie, we're trying to do a study to start finerenone in PD patients who have not seen it before. And to one's point, like we don't know, but I think, if there's no harm, one could argue that while you're waiting for the data, you might want to keep them on it. But again, it's data-free zone, as they say. Anyway, we're at time. Thank you very much for an excellent presentation and overview that included the pathophysiology, the pathobiology, and the rationale for the medications, which I think is really important for all of us. And also some clinical applications. So, and thanks everybody for listening and for participating. And
Thank you, everyone.
happy summer for the rest of it. We only have one more province-wide rounds, which is a unique one, which will be on July the 17th, which is a extraordinary one. But thank you.